Thank you. Good morning, everyone. Thank you all for being here. St. Vincent's Medical Center in Bridgeport, Connecticut. We will shorten that to either St. Vincent's or SVMC. Has filed an application for a certificate of need, seeking approval from the Office of Health Strategy for an increase of 2 or more operating rooms within a 3-year period. Specifically, it is seeking an increase of 3 ORs. It previously submitted 2 notifications of OR increases, one in January 2020 and another in March 2023, neither of which are currently in operation. The anticipated capital expenditure associated with this project is $14,250,000. Today is March 18th, 2025. My name is Dan Chuka. OHS Commissioner DJ Gifford has authorized our Director of Legislation and Regulation, Boyd Jackson, to designate hearing officers for CON matters, and he has designated me to serve as the hearing officer for this matter. Specifically, he has designated me to rule on all motions and recommend findings of fact and conclusions of law upon completion of the hearing. This hearing is being held online utilizing the Zoom video conference platform as authorized by Connecticut General Statute Section 1-225A. In accordance with the statute, any person who participates orally in an electronic meeting should make a good faith effort to state his, her, or their name and title at the outset of each occasion that such person participates orally during an uninterrupted dialogue or series of questions and answers. We ask that all members of the public mute the device that they are using to access the hearing and silence any additional devices that are around them. This public hearing is being held pursuant to Connecticut General Statute Section 19A-639A-E. As such, this matter constitutes a contested case under the Uniform Administrative Procedure Act and will be conducted in accordance therewith, along with the regulations of Connecticut state agencies beginning at Section 19A-9-24. Although I will be asking the majority of questions, OHS staff is also present to assist me in gathering facts related to this application and may also be asking the applicant witnesses questions. At this time, I'm going to ask each staff person with me to identify themselves with their name and their OHS title, beginning with Steve.
Good morning. Stephen Lazarus, Lazarus. My title is the Certificate of Need Program Supervisor.
Thank you. And then Annie.
Good morning. My name is Annie Fiella, F-A-I-E-L-L-A, and I am the CON team lead.
Thank you. Also present is Boyd Jackson, as well as Maida Capozzi, who is assisting with the hearing logistics, gathering the names for public comment, and providing miscellaneous other support. Speaking of public comment, sign up for public comment has started. If you would like to make a statement at today's hearing, please put your name in the Zoom chat and we will be able to provide you with an opportunity to speak later on. Sign up will continue until the public comment portion is scheduled to begin, which will occur immediately following the technical portion of the hearing. The certificate of need process is a regulatory process, and as such, the highest level of respect will be accorded to the applicant, members of the public, and our staff. Our priority is the integrity and transparency of this process. Accordingly, decorum must be maintained by all present during these proceedings. This hearing is being transcribed and recorded, and the video will also be made available on the OHS website and its YouTube account. All documents related to this hearing that have been or will be submitted to OHS are available for review through our CON portal, which is accessible on the OHS webpage. In making my proposed decision, I will consider and make written proposed findings in accordance with Section 19A-639 of the Connecticut General Statutes. Lastly, as Zoom notified you in the course of entering this hearing, I wish to point out that by appearing on camera, you are consenting to being filmed. If you wish to revoke your consent, please do so at this time by exiting the meeting. So I'm going to start by going through the exhibits and items of which I am taking administrative notice, and then I will ask if there are any objections. The CON portal contains the pre-hearing table of record in this case. Exhibits are identified in the table from A to S. Steve or Annie, do you have anything else that you wish to introduce at this time?
I do not.
No, thank you.
Okay. And the applicant is hereby noticed that I am taking administrative notice of the following: the statewide healthcare facilities and services plan and its supplements, the facilities and services inventory, the OHS acute care hospital discharge database, the all payer claims database, and hospital reporting system financial and utilization data. I may also take administrative notice of other prior OHS decisions, agreed settlements, and determinations that may be relevant to this matter, but which have not yet been identified. If applicable, I will provide the applicant with an opportunity to respond to anything I have so noticed. Counsel for the applicant, can you please identify yourself for the record?
Good morning, hearing officer and OHS staff. My name is Joan Feldman. I'm with the law firm Shipman and Goodwin.
Thank you. Do you have any objections to the exhibits in the table of record or the administratively noticed documents?
I do not.
Thank you. So all identified and marked exhibits are entered as full exhibits. Does the applicant have any additional exhibits it wishes to enter at this time?
Not at this time.
Okay. So we will proceed in the order established in the agenda for today's hearing. I would like to advise the applicant that we may ask questions related to your application that you feel you have already addressed. We will do this for the purpose of ensuring that the public has knowledge about your proposal and for the purpose of clarification. I want to reassure you that we have reviewed the docket and we will do so again many times before issuing a proposed decision. Anyone attending today should enable the use of video cameras when testifying or commenting remotely during the proceedings. However, all participants and the public should mute their devices and should disable their cameras when we go off the record or take a break. Please be advised that although we will turn off the recording, audio and visual will continue to be accessible. Public comment taken during the hearing will likely go in the order established by OHS during the registration process. However, I may allow public officials, if there are any, to testify out of order. I or other OHS staff will call each individual by name when it is his or her turn to speak. And as I mentioned before, registration for public comment has already begun and is scheduled to start immediately following the technical portion of today's hearing. We would ask the applicant's witnesses be available after public comment, as OHS may have additional follow-up questions based on the public comment. Attorney Feldman, are there any housekeeping matters or procedural issues you wanted to address before we got into the meat of the hearing?
No, there are not.
Okay, thank you. So Attorney Feldman, would you like to make an opening statement?
Sure, a brief statement. Again, good morning, hearing officer and OHS staff. Today's application is for the addition of 3 operating rooms on the main campus of St. Vincent's Medical Center Hospital. You will hear before you testimony from Mr. Jennings, who will explain the underlying need for the ORs to address the needs of the community served by the hospital. The evidence that you will hear today will unquestionably demonstrate a sustained and effective commitment to establishing an ambulatory network, surgery network. As you know, under Connecticut law, hospitals are permitted to increase the number of ORs they have on an every 3-year basis without having to go through a hearing. And despite the fact that St. Vincent's Medical Center has established a very robust ambulatory network and has migrated about 43% of their surgical cases to their ambulatory network, there remains a sustained need for inpatient operating rooms. That is typically related to trauma cases and cases of individuals who cannot have their surgeries safely performed in an ambulatory setting, typically because they have comorbidities. You will also hear from Dr. Gregg, who is the Chief of Surgery and an accomplished trauma surgeon who will address the challenges he faces on a daily basis to meet the needs of the patients from the community who require surgery in an inpatient setting. Unfortunately, it takes an extraordinary amount of time and resources to try to meet the needs of both the surgeons and the patients. Finally, let me assure you that the hospital has not engaged in any premature activity to open ORs that have not been approved by OHS. Simply put, if the 3 additional ORs are not approved, the hospital have no choice but to close 3 existing small, ill-sized operating rooms, and we'll explain more about that throughout the testimony this morning. I have no further opening comments, and if it's okay with the hearing officer, we would be ready to proceed with pre-filed testimony.
That works for me. I'm going to swear in Mr. Jennings and Dr. Gregg, as well as Barbara Dirty, who's whispering in your ear right now.
Okay. There is one additional housekeeping issue. We will be, during the portion of the pre-filed testimony, we will be projecting a few exhibits. So we need to be able to share the screen if that's possible. Melissa Mayfield, who is sitting here, needs permission to share. And of course, you know, we're willing, obviously, to submit these exhibits if OHS is interested in seeing them more permanently.
I have no issues with you projecting. We just have to make sure that we're able to navigate that on our end.
Sure.
But let me just start by having each of them introduce themselves, including Barbara Dirty, and with their name and their title, spelling of their last name, and then I'll swear them all in at the same time.
Want me to go first?
Yes, please.
Good morning. My name is Barbara Dirty, D-U-R-D-Y, Senior Director of Regulatory Strategy for Hartford Healthcare.
Thank you.
Good morning. My name is Dr. Shea Gregg, and I'm the Chair of Surgery at St. Vincent's Medical Center, Hartford Healthcare, and I'm the Chair of the Department of Surgery.
Good morning. My name is William M. Jennings, Jennings, and I'm the President of the Fairfield region for Hartford Healthcare and Senior Vice President of Hartford Healthcare.
Thank you. And Dr. Gregg, I'm not sure that you spelled your last name for the court reporter, so I'm just going to do that. It's G-R-E-G-G, correct?
That is correct. 3
Okay.
G's total. Thank you.
Thank you.
Hearing officer, to be overly inclusive, in case there are questions that come up, we'd like to introduce a few other people, if that's okay.
Sure.
Samuel Peringer, P-U-E-R-I-N-G-E-R, Director of Strategy and Planning for the Fairfield region.
Thank you.
Christopher Given, G-I-V as in Victor, E-N. I'm the Regional Vice President of Finance for the Fairfield region of Hartford Healthcare.
That would be it.
Okay. So please raise your right hand. Each person who identified themselves. Thank you. Do you solemnly swear or solemnly and sincerely affirm, as the case may be, that the evidence you shall give today shall be the truth, the whole truth, and nothing but the truth, so help you God, or upon penalty of perjury?
I do.
I do.
Thank you. Let the record reflect that they all affirmed.
A request from the court reporter, just have people identify themselves when they begin speaking a new segment, please. Thank you for that. Sorry for the interruption.
No problem. Thank you. So Attorney Feldman, do you need the option of showing the slides now, or have we
Yes.
not gotten to that point yet?
Yes.
Okay.
During Mr. Jennings' pre-file and Dr. Gregg's pre-file, they both would like to show some exhibits.
Okay. Maida, are you able to provide them with access?
Yes. Is it Melissa? Yes, okay, I will do that immediately.
Also, Attorney Feldman, you were just really quiet just now. I'm not sure why that is, but let's just make sure you have the mics where you need them to be.
Okay, is that better?
Yes.
Okay, great. So we'll wait for you to let us know once we're able to share.
It looks like we can
I
share.
believe you are ready. I just wanted to double
Okay,
check.
Okay, you want-
she's checking.
Yep. Okay, I'll go to slide. Okay, awesome.
Okay.
Yeah.
Good morning, Hearing Officer Shuka and OHS staff. My name again is William M. Jennings, and I am the president of the Fairfield region for Hartford Healthcare and senior vice president of Hartford Healthcare. And I have been a hospital president or CEO since 1997. Before I begin my testimony, I'd like to adopt this pre-filed testimony as my own. The CON application before you is a request for the approval of 3 additional operating rooms at St. Vincent's main campus. While not a large number of ORs, they are vitally important to the hospital and its patients. When I arrived at St. Vincent's in 2021, it was an underperforming hospital needing much improvement with respect to its operational and physical infrastructure. Prior owners had neglected St. Vincent's with a lack of reinvestment. Since my arrival at St. Vincent's, we've endeavored to reinvigorate the hospital. As a result of our efforts, the hospital has experienced strong and sustained growth. When I arrived in 2021, a master facility plan had been developed, but unfortunately put on hold, of course, because of the COVID-19 pandemic. One of the key components of the master facility plan was the build out and renovation of the hospital's main campus ORs. In fact, I'd say it was the uniform #1 priority of the master facility plan. After the pandemic, St. Vincent's was able to refocus its planning efforts and continue to successfully recruit new surgeons to the hospital. Because we understood that the successful recruitment required more ORs, the need for additional and modernized ORs became the top priority. As a result of focused planning, St. Vincent's has been able to successfully recruit 37 new surgeons to the medical staff. And this is where I'd like to refer to the first exhibit, if I might. And again, administratively, is it okay to roll? This exhibit is a rendering of 2 floors of the OR suites at St. Vincent's. The second floor is where we currently have 5 ORs. They're labeled OR 17, 18, 19, 20, and 21. Those are all currently operational. And in our testimony and in the application, we referred sometimes to the smaller ORs, the dated ORs, more constrained ORs, or sometimes suboptimal ORs. If any of those descriptions are used, it's referring to those 5 on the second floor. The third floor is represented above with an existing 10 operating room suite. Those are our larger, more modern operating rooms. To the right of the operating rooms labeled 1 through 10, you will see the 2 operating rooms previously approved by OHS and 4 additional ORs that are currently under construction. This summer, we will complete the construction and we will have 16 operating rooms immediately adjacent on the 3rd floor, 6 of which will be new and appropriately sized for equipment that Dr. Gregg can describe in more detail later. So this exhibit was put together because it could be confusing as we're talking about existing operating rooms, new operating rooms, or replacement operating rooms, or even sometimes if we refer to something that we would decommission. In the opening comments, there was a reference to the potential of decommissioning should the CON not be approved, and the decommissioning would happen on the 2nd floor in one of the operating or in the operating rooms labeled 17 through 21. It is, of course, our desire to not do that based on current inadequate OR capacity. Today, with advances in surgery, the hospital requires ORs that are able to accommodate advanced imaging and technology, and with that comes more need for electricity and more equipment. Our 2023 refreshed master facility plan included the addition of the 2 previously approved OHS approved ORs, along with the 3 new ORs. When the OR enhancement project is complete and pending OHS approval, the hospital will have 16 right-sized ORs on the 3rd floor and 4 smaller limited use operating rooms on the 2nd floor. As you will hear more from Dr. Gregg, innovation has led to the convergence of surgical, diagnostic, and interventional procedures and the need for right-sized ORs and modernized operating room space. Our community of patients deserve high-quality, innovative care, which we firmly believe results in better outcomes and cost savings. With your approval for the 3 much-needed additional ORs, we'll be able to continue to serve Greater Bridgeport, the Greater Bridgeport community, and provide timely access to high-quality surgical care. Thank you for your time, and I welcome any of your questions.
Thank you. This was very helpful to see in this form. So thank you for putting this together.
You're very welcome. We have pre-filed testimony from Dr. Gregg. If we may proceed.
Yes, absolutely.
Thank you. So good morning, Hearing Officer Chuka and the OHS staff. My name is Dr. Shay Gregg, and I'm the Chair of Surgery at St. Vincent's Medical Center Department of Surgery, and I adopt my pre-filed testimony as my own. On behalf of St. Vincent's Medical Center and in my capacity as Chair of the St. Vincent's Medical Department of Surgery, I'm here to request OHS's approval for St. Vincent's Medical Center to add 3 additional ORs to the hospital main campus for a total of 20 ORs. As I stated in my pre-filed testimony, I'm a trauma surgeon by training, and I've committed my professional career to servicing the patients of this community. More specifically, as the Chair of Surgery, my primary objective is to ensure adequate access to high-quality surgical care for all patients without regard to socioeconomic status or other demographic distinction. When I arrived at SVMC, it was very apparent to me that SVMC had inadequate OR space, and that if I was to attract new qualified surgeons to meet the needs of the community, I could only do so with adequate OR capacity to accommodate the scheduling needs of other surgeons and modern surgical facilities that could safely incorporate advanced imaging and surgical equipment to provide the needed care. Since my arrival, we have recruited 37 new needed surgeons who will all be fully onboarded to the SVMC medical staff by 2028. More precisely, SVMC needs ORs that can accommodate new equipment, improve workflow efficiency, enhance patient safety, and integrate advanced equipment to perform more minimally invasive surgeries. This is needed to recruit talented and qualified surgeons that they are receiving this training during the residencies nowadays, and ensure quality care, staff satisfaction, and ensure safety and evidence-based surgical care. Furthermore, specifically, my support for these ORs is based upon the following needs. 1, technological integration of robotic arms, imaging systems, intraoperative navigational tools, and greater power sources. 2, enhanced workflow to optimize staff movement for increased efficiency in case transitions. And 3, maximization of patient safety by incorporating specialized lighting, ventilation systems to minimize infection risk, and ergonomic design for staff health and comfort. So if we can pull up an exhibit that we submitted regarding block time. So just about every OR at a major medical center like St. Vincent's Medical Center assigns block to individual surgeons based on the specialty, the amount of patients they see, and to ensure that people receive high quality surgical care. What you see in front of you is our block schedule that we anticipate when we open our new ORs in July of this year, 2025. And as you notice, the red block that you see, the deep red block there, are the anticipated new blocks that we will be adding along the way for our new surgeons that are coming onto our workforce. And there's a second screen here, I believe, that this is the ongoing. Notice there you have these new rooms that we're opening, OR 11, 12, 14, 15, 16. You can see the names of the rooms at the top, and then we have the 2 robotic rooms. Notice there's not a lot of things that are white and say open. Open is the opportunity to put a case in that room because it has not been previously blocked for elective surgery. So if I can go back actually to the previous exhibit real quick. If you notice, it seems like, okay, we have a lot of open time to potentially put cases in these rooms. Since the publication of this, notice this last update was at the end of January. We have taken up about 40% of these blocks with additional recruits that are coming in to serve some of the most underserved populations that are in Bridgeport and our surrounding communities. Some of these include ENT, some of these include colorectal surgery. But again, we constantly are looking to serve the needs. We do, very frequent needs assessments on what our population needs, and by hiring those specific specialty surgeons that require specialty tools to better, reduce cancer, take out colon cancer, catch it early, et cetera. They're going to need elective time in order to book into. And I would say 40%, it's 40% of those open blocks have already been assigned to anticipated surgeons that will be joining our staff by July of this year. So as you can see, we anticipate a significant increase of our OR growth. And ultimately, by using our 17 ORs, we are projected to be at about 95% capacity by the end of fiscal year 2025. So with only 17 ORs, there are very few open blocks and open times in the OR schedule, which is unsustainable and does not allow us to efficiently accommodate emergent cases or traumas. And we'll talk about trauma in a moment. As a practical matter, OR utilization above 75% is very difficult to manage and leads to frequent bumping and shifting of cases to accommodate traumas or emergencies. And we are right around that number now. And so when we get that emergent trauma patient, that emergent cardiac patient, that emergent orthopedic patient, we have to shift the schedule around sometimes 2 to 6 times in terms of delays, cancellations, et cetera, a day as we are entering into our expansion. So we already are operating near the 75% capacity as is. We'll expand. We anticipate even further growth. And yet, for those emergency patients, we will always accommodate an emergency. But unfortunately, we have to move people around to push back elective cases, et cetera, to make sure that patients get the care they need in the timeliness that they need it. So I can tell you that firsthand that frequent bumping and shifting, as just mentioned specifically, leads to decreased surgeon, staff, and patient satisfaction. And that is not what we want at St. Vincent's Medical Center or anywhere else through Hartford Healthcare. So regarding capacity, capacity issues at St. Vincent's are not related to ambulatory surgery cases, which have been appropriately migrated out of the main campus. And we can dive deeper into that question should we need to in later testimony. But we have looked at our patient population, and the cases that go to the ambulatory center are being done in the ambulatory center. This is actually a surgeon-driven decision with anesthesia and preoperative admission testing. It's an entire group that makes these decisions. But the reality is we have sicker patients in Bridgeport, and they need to be done in a hospital setting in order to ensure the safest care that we can possibly provide some of these patients. So we have definitely worked tirelessly to build an ambulatory surgery center network with multiple surgery sites, ambulatory sites. But again, it is patients are triaged based on the comorbid disease and a variety of other things on whether we perform the case in the hospital or we perform the case in ambulatory. So these needs have already taken that into consideration, and we remain here still asking for the CONs on the 3 additional ORs. If we can move to slides 5 and 6. Okay, so Bridgeport is one of the 5 cities in Connecticut with the highest number of trauma cases. What you see in front of you is actually from a database that, as the state trauma committee chair, we have worked with the state where all the trauma centers submit their data, and we perform basically a heat map of where traumas are most commonly admitted or seen in hospitals around the state. And the darkest colors are the areas that you see, high volumes of trauma. And Bridgeport sits there. We are one of 5 cities in the state with the highest number of trauma cases. So year over year, to give you an idea with some specific statistics, for St. Vincent's from calendar year 2023 to calendar year 2024, St. Vincent's has experienced a 15% increase in trauma cases. That is a significant number where rapid surgical interventions could be required, and we need to be ready for these patients. So where is the growth coming from? So we are obviously in contact with our additional trauma center within the city. They're also seeing this equal amount of growth. And the growth that we are truly seeing in terms of the age demographic are people over the age of 65 who fall and they take an anticoagulation. So geriatric trauma, which I have published on, is growing. It is not only a national epidemic where people are dying from this. I believe at last view of national databases, there were 41,000 deaths of people over the age of 65, and it's increasing every year because we're all getting older. We're all trying to age in place. We're trying to live fuller lives more independently. But at the same time, gravity is not changing. And we are seeing significant growth in geriatric-related trauma. Plus, St. Vincent's Medical Center is a regional referral center for a variety of centers that range all the way up to Vermont or New Hampshire, where they are looking for help to manage their trauma patients. Some of these systems are unable to accommodate these patients because of bed-related issues. And I believe I have actually seen and witnessed and built a system with my team, both at the administrative and the frontlines clinical team, to take care of these patients. So we have become a destination tertiary referral center for a variety of other regions in the surrounding New England communities. So with this growth that we have seen in trauma, the 3 additional ORs, which would bring a total number of ORs to 20, we're projecting OR capacity again to 85% by 2028, at which time we will once again need to evaluate capacity based on the growth trajectory that we are on. So to get back to some key things, since my arrival, I have seen consistent growth, which is truly remarkable, and it's a testament to the commitment of leadership to build high-quality, state-of-the-art surgical care. And for all these reasons, I respectfully request that OHS approve the request for those 3 additional St. Vincent's Medical Center operating rooms. I'm very happy to answer any questions that you may have, and thank you.
Thank you. Attorney Feldman, is there anyone else you wanted to have make an opening
Can't
statement?
hear you.
It's on mute.
Steve, Annie, can you hear me? Okay, you could hear me now,
Yeah, I
Attorney
can hear
Feldman?
you.
Okay.
Yes.
Attorney Feldman, is there anyone else you would like to have make an opening statement at this time?
No. No,
Okay.
thank you.
So before we move off that presentation, we did have some questions that came up. So would you mind pulling that up, starting with the first page? I'm going a little bit out of order. I sort of had an idea in my mind of how I wanted to approach this hearing, but I think it makes more sense to start here. So there's a little bubble there that says if OHS does not approve 3 new ORs, 3 of the suboptimal ORs will be closed, equaling 17 ORs. So what would happen if we approved 2 new ORs?
We
With-
decommissioned the other 2.
Okay, so it's like 3 for 3, 2 for 2, 1 for 1, sort of.
Yeah. To be
Okay.
clear, though, I want to reemphasize the inadequacy of the capacity that Dr. Gregg reviewed. So, but we're going to follow the guidance and the law.
Okay. Another question I had on that is, you mentioned, so OR 13, 14, 15, and 16 are currently under construction, and that those are expected to be completed by July of 2025. That the fact that you skipped over OR 11 and OR 12 would sort of indicate that those have already been built. Is that correct?
No, operating room 11 through 16 are currently under construction as an adjacent suite to the existing 10. So
Okay.
it's one construction project, 11 through 16.
Okay.
And the name of the last speaker, please?
William M. Jennings.
Thank you. Apologies for the interruption.
No, thank you, Mr. Dixon. Feel free to interrupt whenever it would be beneficial. Can we turn to actually one other question? When we were talking about this slide, it was also mentioned that you had recruited 37 new surgeons. Somewhere in the record it says you have 11 starting this year. Are those 11 in addition to the 37, or are the 11 that are starting this year part of that 37?
So that's part of the 37.
Okay, so it's not 46, it's 37 that
Yes,
have started since I think 2021 through until now.
that is correct. Yes.
Okay. So we can turn to the second slide now. So number one, I think it would be helpful if this was submitted as an exhibit, Attorney Feldman. So if you can do that as a late file, we would appreciate that.
Just this one, not the previous slide?
Oh, no, I mean the entire presentation.
Okay.
My apologies. So we have OR time is taken / utilized versus available OR time. So there's a distinction between taken and utilized. So just because something is a colored block doesn't necessarily mean that there is a booked surgery. Is that correct?
So the simple answer is that's correct. However, let me actually be very clear about our process for assigning block. We have a perioperative governance committee that's based on, that looks at our block assignments every single month, sometimes twice a month. And we assign block based on 2 things. One, merit. Are you filling your utilization expectations of greater than 75%? Otherwise, you will lose block. Again, you have to account for people are always going to take vacation and those sorts of things. But bottom line is, are you fulfilling your block obligations based on our algorithm? and which ultimately dictates, will there be a patient in that OR? So wherever you see red, wherever you see a different color there, that's basically a different specialty that's represented. Where you have surgical oncology, I'll give you an example, as it might be one color, and then plastic surgery with breast reconstruction might be another one. Primary breast cancer surgery is another one. Colorectal surgery is another color, orthopedics, neuro, et cetera. So there's all these different colors. And we try to align them so they can see patients in the office, et cetera. Think of the elective cases as these are patients seen in the office, and this is our service to the community based on the community needs. So there is a high likelihood up to, if you take adjusted block and other calculations that we have done, there is a high likelihood of over 85% that there will be a patient in this block receiving a surgery at any given time. So wherever there's a colored block, that's how you can sort of look at that. When you have open time, the open time is a more complex, but I will break it down to this sort of concept, is that we have not only our elective cases that come in from the office based on the community needs, but we also have add-on cases to the tune of about 15% or more. I see that growing right now, especially as trauma volume grows, acute care and emergency general surgery trauma grows, or emergency general surgery grows. So even though you have open time here, we will try to put in cases into that open time for add-on sort of situations. As I mentioned initially, that open time that you see there, since the publication of this, about 40% of that has actually already been assigned to new surgeons and new recruits to service underserved areas within our population, specifically colorectal. We're looking into ENT, not even looking into where ENT is another specialty as well. So where you see open here, that's actually going to be assigned blocked in order to manage the population for these underserved specialties within the Bridgeport and surrounding communities. So if you take 40% of that open time away, our ability to get the emergencies or the add-ons, et cetera, becomes progressively more challenging, where we are, again, back in the exact situation we are in today of bumping cases, moving cases, potentially canceling cases, really depriving people of the essential surgeries that they came into the hospital to receive. And with these additional ORs, we will have that opportunity for more open time, but also, based on our growth trajectory and projections, I also believe that we will be able to better service the elective schedule with time, as time goes on.
Okay, thank you, Doctor. I think something that would be helpful would be to have all of these colors identified with like a legend, just so that we have an understanding of which specialties are going where. And you also mentioned that this has been updated since it looks like January 29th, 2025. So the open spaces aren't, like 40% of them aren't actually open.
60% of them are open. 40% of them have been reassigned for the purposes of managing an elective schedule for underserved specialties. Yes.
Okay. So if we can just sort of have updates to this made and then submit it as a separate late file, that I think would also be helpful.
I just want to clarify one thing in terms of the white blocks. As you can see, some of them are sequential white blocks, which would obviously allow for a surgical case to be moved into that block. But surgical blocks that are 1 or 2 are typically inadequate in terms of time to move a case into it. So, and we can explain that in the updated legend too.
Okay, that would be helpful. Thank you. So I suspect I know the answer to this, but I'll ask the question. Are there specific reasons certain specialties are in certain ORs?
The answer, yes.
And what are those reasons, if you could provide some examples?
Sure. So, so as you saw on the other exhibit, if we could just go to the other exhibit where the new ORs are, notice how packed that is with, specific colors.
Go back to the slide 2. That one.
Yep. So we have the new 6 ORs, and then actually, if we could go to the block schedule, we'll go to the other one because right there, basically. So in these new ORs, these are larger ORs that can accommodate the navigational imaging that is required for robotic surgery, which ultimately will reduce your time in the OR if we are able to immediately, zoom in on the exact levels, et cetera. So that machine is actually quite large and it needs to be brought into the room. There's the O-arm or the O-arm CT, which is a large device that needs to be brought into the room. So a lot of these rooms are anything from spine surgery to neurosurgery to orthopedic surgery, where we require, again, which has been shown to reduce time in the OR, et cetera, to accommodate this equipment. Plus, many of these rooms are lead lined as well. So again, maintaining the highest safety standards as far as radiographic imaging. So between imaging modalities, location modalities, robotics, and just the sheer amount of equipment that is needed, these rooms are, for lack of a better term, right-sized to accommodate those specific, cases, whether it's orthopedic, neurosurgical, or spine surgery, which actually is split between 2 specialties. So the size of the case matters, and the location of the case is actually important. So, and as far as the other cases as well, whether it's the number of lights that are in the room, can you fit a robot in the room, your laparoscopic equipment, et cetera. Each of the other rooms, those other 10 rooms, if we go back to the other schedule, like if you notice, there's a lot of one type of green on OR1. That is a surgical oncology room that really has the laparoscopic capabilities of best serving that population for a majority of the week and for other parts of the week. If you notice, there's a lot of yellow in OR, I believe it's OR5 there. That is the best room to accommodate microscopic surgery for special types of breast reconstruction called deep flaps. So again, as part of the overall efficiency plan in building these OR outs, turnover times and making sure the patients are getting into the rooms on the times or at the times that they are scheduled, we want to make sure that we have these rooms that are, almost dedicated to these specific types of specialties. And that will ultimately, we know that if that OR5 is microscopic surgery, we know that OR1 is mostly surgical oncology, especially complex hepatobiliary, then we can have that equipment, sitting outside the door as opposed to all the way down by room 16, where orthopedics is going to have their stealth equipment and other things. So I gave you a very long answer to a question. But the bottom line is these rooms, we are trying to cohort types of cases into the individual rooms. And by doing so, we will ultimately improve efficiencies and hopefully just patient care outcomes.
Okay. I favor explanation over brevity, so I appreciate that.
Thank you. Thank you.
The earlier in your statement, you made reference to some imaging capabilities, like the intraoperative imaging and CT. What do you currently have for those ORs versus what will you be seeking?
So right now, we actually do have a variety of pieces of equipment that, based on capital, and I will defer to others to better comment on it. But what I will say is that we do have stealth imaging systems. We do have CT imaging systems. We are looking to actually increase our robotic based systems at this time. And what I can say is we do have what we need based on the number of rooms that we have. But as part of the capital expansion project and just looking to the future and what the market is expecting and what the data is coming out and supporting nowadays is it's showing the benefits of these advanced modalities. So it is quite clear, the writing is on the wall, that in order to really provide, advanced care at a tertiary academic facility, destination facility, we are likely going to even need to grow these other assets in order to provide the services for the patients in a very efficient, safe manner. So that's where we are as far as what we have and where we're going.
Hearing Officer Sika, this is Bill Jennings again, the president. We are not seeking any approvals for additional equipment that is governed by OHS.
At this time.
At this time.
Okay, thank you. Let me see if I have any other questions on this. So that the scheduled, you may have responded to this, but I'll ask it as a more pointed question. What percentage of the scheduled blocks are used?
As far as our utilization,
Yes.
so when we look at our, and I want to just clarify your question too, as of today or as of what we project?
Both.
Okay, so we are, we look at something called almost the audited utilization time. And we are running anywhere from 85 to 86% utilization as of today. And that takes into account, all of our specialties based on the OR complement that we have at this point. And again, remember, the national standard is roughly, when you start clearing 75%, and you can see this in many publications, that when you start clearing 75%, many times, not many times, but hospitals will start looking to build additional ORs. Fortunately, from an administrative standpoint, this plan to build the new ORs is almost hitting us just in time. That we have cleared the 75%. We're getting up into the 80% and higher, and we're at about 83 to 86% utilization as of today. When we bring on these new surgeons and these new blocks, et cetera, I believe that we have repeated the number 85% anticipated capacity right out of the gate, but up to 95% capacity anticipated by the end of fiscal year, the end of 2025. So the growth trajectory is there. And the real reason is the onboarding of surgeons to serve a lot of these underserved populations and assign them block. So that's where we are, and that's where we're going, and that's what we anticipate, if I can provide that. We're at 86% with these new blocks, about 85+%, and we anticipate hitting up to 95% capacity shortly into fiscal year 26 even.
So 86% of what, I guess, is the question. What's the denominator? Is it 86% of the total scheduled, or 86% of the scheduled blocks, or?
Sure. It's the number of minutes over the course of a week, divided by the number of minutes in the OR. But we also account for, there's variations in start time and other things like that, to the tune of like 15 minutes here, 15 minutes there, a 7:15 start versus a 7 o'clock. We try to stagger things to do things safely from an anesthesia utilization standpoint. So when we look at all that and we take out the time that is, which is very limited, to calculate our utilization, think of it as very basically as the total number of minutes in the week during our prime time, which is 7 a.m. to 3:30 p.m., and the number of minutes that are actually in the OR. All right, as in patient wheels in the operating room, getting anesthesia, to wheels out, case completed, minus, sometimes some turnover time, et cetera.
Okay. And maybe this is just showing a lack of understanding on my part, but is there a reason why you can't perform surgeries after 3:30?
No, it's actually, this feeds into the ask as well. Thank you for asking that question. Traditionally, we are running 2 to 6 rooms after 3:30. All right, so a standard metric for many places is as prime time utilization. Prime time is very, very typically 7 to 3:30. When as defined, at least in our system and many other systems that I've worked in. Okay, so that's prime time utilization. We very much are going beyond that 3:30 block into the night, very much so. And the reality is, as far as an elective case, I mean, if we think about it, we're asking patients to be NPO, so they don't eat anything, and then come into the OR at like 3 o'clock. And let's say we were to do an elective case on them after they are NPO after midnight, and then they can, they'll get their case. But that means that they've been NPO over the course of the day. Some patients that, again, we operate on higher comorbid patients, meaning they have diabetes and a variety of other things. So yes, we operate beyond 3:30. In fact, we have staff holders to make sure we provide those operations. Emergency add-ons traditionally will go after 3:30 because we are trying to get them in during the day, but we are having challenges due to access to block. So we are, really triaging. We built a whole triage system about that. So to answer the question is, we are operating beyond 3:30. And we anticipate continuing to operate beyond 3:30, but this is where, prime time is where you want to try to get your best get your operations done, and which is ideal for the patient, quite honestly, when it comes to NPO status, medications, and a variety of other things.
Just also, I mean, that's the standard in the hospital industry across the nation. And there's a reason for that, because the surgeons are physically available typically during those hours should some complication occur. Also associated with the surgery is recovery room time, where the patient is still very acute post-surgery. So all of that extends out well beyond 3:30. And it's not unusual that patients would have to return to an OR. And of course, you can't plan for trauma.
So is it fair to say then that for the most part, like elective cases are not scheduled after 3:30? Those are more, the unexpected trauma cases?
They are not scheduled, but overage time is an issue within our operating room. In sense that, let's say that a trauma comes in, or an emergency cardiac case comes in, or an emergency general surgery case. We have built an elaborate triage system based on condition that will direct access to specific ORs within 15 minutes, 2 hours, 4 hours, or 8 hours, okay? And we will meet those metrics by trying to get patients into specific rooms to get the care they need. And if you make one move, that could have 5 other moves associated with it that could actually push cases back, et cetera. And like I said, we will see cases go beyond the 330 mark, about 2 to 6 cases a day. I'm very, very front lines and looking at that board, trying to find efficiencies with the team, the nursing staff. So there's a variety of reasons, whether it's bumps or trauma access or cardiac access, emergency access, that ultimately are pushing cases back. And I think that we have to remember something core to this argument as well. Surgeons are still human beings. And I think yes, we wore a badge on our scrubs back in the day where, oh, I was up for 48 hours. People have families, people have lives, and yes, they're going to dedicate their lives to patient care, number 1, 2, and 3. But the reality is if we have the opportunity to potentially get, that surgeon home to finish their cases on time based on the block schedule that they have so they can go see their kids' performance at 6. I know I've missed many of my kids' performances over the years as a trauma surgeon. I think we have to be humanistic about this too. That's more of a background statement, but I think that does play a role here in addition to everything that has been said.
Okay, and another question about this chart here. On the left side, it says first, second, third, fourth, fifth. So that would take us from 7 a.m. to 3:30. Is that correct?
We say yes, 7 a.m. to 3:30 is the quick answer.
Okay.
Sometimes we'll try to get patients in, it's 7:30 to 3:30, but we will try to get patients in, especially for longer cases at 7. We will, we try to be as efficient as possible. And just of note, as far as just the commitment to our surgical staff and our nursing teams, we have a first case on time start that is exemplary across this health system. And I'm extremely proud of the team to do this, of anywhere from 86 to 88%. Namely, that case is in that room 86 to 88% of the time. And if there's a delay, you're looking at 1 to 2 minutes. And this is a quality metric that we focus on. And it's very important to every single member. And to hit that sort of first case on time start metric is very impressive for our heart. So we try to use every minute of every day that we can, I think, especially when it begins the day.
Okay. Sorry, I'm still just trying to make sense of this chart a little bit. So when you say first, what is like first what?
Sure. So we can go through actually a little bit more. Let's just take one OR. We'll just say we have one OR here. If we look at OR 1 on Monday, you have an AM and a PM block. Okay. Notice if you go to OR 7, well, you have a blue and then you have a red. Well, that's because there's 2 different specialties that are in that room. But the bottom line is, let's just say you have an OM and an AM and a PM block. The AM block, the AM plus PM is your prime time. All right. So that is your 7 to 3:30 on a daily basis. So your morning block, your AM block, goes from 7 to 12, we'll say. Okay. Your PM block goes from 12 to 3:30. All right.
Okay, I was misreading that.
Yeah, honestly, it took me a while to understand this chart too, just coming in and onboarding. But yeah, if you look across, that's the first Monday of the month. And we look at OR1, we know that there is a specific surgeon, I'll say a surgical oncologist, that is actually operating for that, roughly 480 minutes during that block. All right, roughly the 8 hours or so. Okay. So they have an entire block day dedicated to do hepatobiliary surgery. All right. So we aim to get them in that room on time. They will likely, because they do very long cases, they will potentially do a 6 to 11-hour case, depending on the complexity of the surgical resection that needs to take place for complex abdominal cancer. And that surgeon's block so he can take care of cancer of that patient. And that's how, if you just look across, that is the second Monday, third Monday, et cetera. And then you break it down to AM versus PM, which are the columns.
May I clarify something about surgeons and their time? Every single surgeon sees patients in his or her office before surgery and cares for patients after surgery. So all of their time is not in the OR. So they can't be up all night operating if they're going to be taking care of patients in the day when they're not in the OR. And if you've ever had a family member go through surgery, everybody wants the surgeon to be operating on them first, not the fourth case in the day, because surgeons do get tired, nurses get tired, and that's so this block is really a realistic representation of the window of time for surgeons to perform their cases. Is that fair?
That is very fair. Thank you.
Okay. Attorney Feldman, I know you know this, but anything
Yeah.
you say, I can't rely on. So
I'll say it again. I'll say it again in my closing.
Okay. Well, yeah, I was gonna say if you want to try to have one of your witnesses say that through like
Go ahead.
cross-exam or redirect, that would be helpful.
Absolutely.
Well, okay, so I cannot ask that question now to Dr. Gregg.
Sure you can, but
Okay, so Dr. Gregg, for a majority of the surgeons that perform surgery in the hospital, is there all of their time spent in the OR?
No.
Can you explain?
Yes. Not only is the operative management of patients a priority to surgeons, but the preoperative and the postoperative care is also important, is imperative to the safe delivery of surgical care. So this block is representative of their operative schedule, but at the same time, they will spend time in their office for the purposes of taking care of the patients both pre-op and post-operatively.
And what about time spent in ambulatory surgery locations? Do they also perform surgeries in an ambulatory setting during the day?
There may be procedures and or operations that are performed in ambulatory settings, so long as the patient meets criteria based on low numbers of comorbid disease, et cetera. And there's certain anesthesia criteria for that. So yes, they are going to see patients preoperatively, postoperatively, make sure that they're recovering fine, managing those patients. But they will also potentially spend some time in the ambulatory suites for anything from performing colonoscopies to doing minor procedures.
So my question is, if all of their time is not spent in an inpatient OR, they might be also, that same surgeon might also have cases in an ambulatory surgery center. So besides seeing patients in the office before and after surgery, they're also doing ambulatory cases at another location. So they're very busy. Is that correct?
Yes.
So it'd be difficult for them to extend their hours beyond 3:30 is my question.
Yes, and I know many of surgeons will actually, after their day is finished, will go back to the office for the purposes of seeing patients after they potentially did 4 or 5 cases in order to take care of their patients. I mean, that's what surgery is all about. And that is a frequent occurrence, and it doesn't matter the time of day, but they are dedicated. They're a dedicated breed.
okay. Thank you. So which of these ORs would be decommissioned? Or do we need to look at the next? No, the next slide is the new one. So which of these would be decommissioned?
This is Bill Jennings again. The,
I meant
Rooms-
on the other chart. That one.
Same
oh,
place.
Yeah.
I don't think any of the rooms on the second floor are visible in this exhibit. They are not. This was for the purposes of giving an overview of what block scheduling looks like and the overall inadequacy of capacity, both currently and in the future. It is not meant to be a complete exhibit of the blocks on the second floor and the third floor.
Okay. So when you provide an updated version, would it be possible to receive something that includes everything, all of the ORs?
Yes. Yes.
Yes.
And identify in some way which ones would be decommissioned versus kept online?
I think it's worth reiterating, this is Bill Jennings again, it's worth reiterating that the projections that Dr. Gregg reviewed on capacity did not include any decommissioning.
Okay. Um, let's take a 5-minute break and we'll come back at 10:21. I do have more questions, obviously. We're really just sort of getting into this at this point. But I think that's all the questions that I have on that. I just wanted to check with the team first. So, Maida, you can stop the recording and we'll be back at 10:21. Thank you. So this is the hearing regarding St. Vincent's Medical Center proposed increase of ORs. It's docket number 24-32757-CON. And we were in the technical portion of the hearing today, and Attorney Feldman requested that one of her witnesses provide some additional details about some of his earlier testimony. So she is going to ask him some questions, I believe.
Thank you. Attorney Feldman speaking. Mr. Jennings, with respect to the second floor on exhibit, if you could go up, Melissa, to the exhibit 2,
Page 2.
page 2 of the ORs. Great, thank you. So what we've referred to in our submission to OHS of the ORs on the second floor, there are 1, 2, 3, 4, 5 ORs on the second floor. One is basically being utilized potentially to build another OR that is modernized and right-sized and that could accommodate the types of advanced surgical equipment and imaging that Dr. Gregg referred to. In terms of these, keeping these second floor ORs open and available to the surgeons, tell me a little bit about what your thinking is with respect to why that would make sense to do, in addition to your projections.
Sure, thank you. Again, this is Bill Jennings responding. The case mix index, the surgical case mix index, the complexity of cases that we are performing at St. Vincent's has continued to increase significantly. However, there will remain some surgical cases that are less complex, that we can continue to use the smaller rooms on the second floor that are already currently staffed and equipped and operating extremely safely. By keeping the 4 rooms open on the second floor, it adds no new costs to the system because they're already staffed and equipped. Furthermore, if in fact we were to decommission 1 or 2 or 3 of these rooms, it would leave a very inefficient OR standing by itself on the second floor, which is difficult to staff. in a productive manner and to have a PACU immediately adjacent that's appropriate. So 3 key points, or the third point, and then I'll recap. The third point is to reopen them and recommission them at a later date would add costs in the future after they sat empty for a year or 2 or 3. So 3 points. No new cost is being added by keeping OR 17 through 20 in this exhibit open. And reopening would add cost, and running them anything less than 4 would be inefficient for staffing.
So being able to utilize those ORs on the second floor, would that give you more flexibility and capacity on the third floor ORs?
Yeah, yes, and I'll defer to Dr. Gregg on this, but it would leave the third floor for more complex cases requiring more space due to new equipment, new technology, and more human resources being in the operating rooms to successfully complete the case.
So with respect to the project to modernize the ORs on the third floor, the OR 16, 17, and some additional modernization, so we have a total of 16 ORs on that level of the third floor. In the CON application, there's a reference to the cost for that project, but does that cost reflect singularly the cost for the modernization of those ORs? Or are there additional costs that are unrelated to the OR expansion? It's the total project cost, or just for the OR modernization?
Just for the third floor.
Okay. All right, so that cost was simply for renovating and building ORs that would accommodate the type of advanced equipment that you need today to perform minimally invasive, safe, cost-effective surgery then?
On 3, yes.
Yes, okay, thank you.
Okay. Mr. Jennings, can you pull up Exhibit N, page 160? That's the pre-filed testimony issue responses.
No, it's the issues responses.
It's tab 4.
It's right here.
So that sheet shows case mix index by surgical specialty. You said St. Vincent's CMI has gone up significantly. So in 2021, it started at 3.476 in total. Then it went down, some more. And then there was a jump in 2024 up to 3.575. Well, not necessarily Mr. Jennings, Dr. Gregg, do you have any explanation for that jump?
Given the years that it occurred in, I would think that, operating on COVID patients would increase your case mix index and the ICU sort of requirements that would go along with taking care of those patients. I would need to dive deeper into the data to assess that, but I can say that that was a very unique time in our history. And those were very sick patients. I lived in the hospital for 3 months during that time. And I could say that probably did play a major role in that during that time period. So I will have to get back to you for details, but I would imagine that did play a role.
Okay. So a higher case mix index means higher acuity, meaning greater likelihood of on-campus surgery, correct?
Correct.
Okay,
Yes.
all right. Um, so before we leave this, if you look at the acute care and general surgery line, that has decreased over time. At the same time, though, the volume of those surgeries has increased at the hospital. Do you have an explanation for that?
Yes, and thank you for pointing that out, actually. So acute care surgery is your emergency general surgery, trauma, and surgical critical care. General surgery is usually referring to the elective cases that are out in the community. When you are doing more elective cases, and basically this was all thrown into one, one tab. So it's to segregate out acute care surgery from general surgery. Those are two different patient populations completely. What I can say that this is reflective of is that our elective general surgery practice has increased. But I can also say that as acute care surgery has increased, the majority of injuries that I described before includes patients that are over the age of 65 who fall on anticoagulation. The major injuries that keep them in the hospital right now are going to be hips, ribs, and heads, head injuries, intracranial bleeds. And what I will say is that not every one of those patients, especially if you have rib fractures, if you have head injuries, et cetera, necessarily will need an operation. So the bottom line is you have, I think, general surgery, which is elective, mixed in with acute care surgery, and you might not have multi-trauma that is going to add to the case mix index, but I believe that we're still taking care of sick patients, period.
Can I use two examples?
What's that?
I'll use two examples if I may.
Please.
State your name.
This is Bill Jennings again. Two examples just to illustrate. As general surgery volume increases, two of the more common cases that a general surgeon would do is hernia or a what was this? Cholecystectomy. They're low case mixes. So as that volume grows, being on a lower end of the case mix index, it would drive that top line down over time, even though volume's going up. And by the way, those are perfect cases to do on the second floor because they don't require high technology.
Okay. So I understand why acute and general surgery were combined. Is it possible to untangle those and provide two separate lines? One which shows that the two lines would show the trends that Dr. Gregg was just explaining. If it's not, that's possible, or if it's not possible, just tell me and we don't have to do that. But I think that would be helpful to see.
Can we take a second, please? Go off.
Sure.
Okay, we're back on. Hearing officer.
Okay.
So with respect to your question, hearing officer, as to whether or not we can break this down further, it would be very onerous, but we want to be able to be as responsive as possible. Couple of things to take into consideration: that over this period of time here, CMS itself assigns case mix index amounts to surgeries, and it changes on a regular basis. So some of the fluctuation that you might see here can be attributable to those modifications done by CMS. That's one. Two, what we can do is break out by our surgeons that are not performing simply general surgeries, but they tend to be doing the more trauma cases, complex cardiovascular cases. We can provide for you, for a list of those surgeons, their case mix index. It would be very difficult, for, if not impossible, for us to do it by procedure. We just don't have that data. So my question is whether or not that would be something you would be interested in us providing.
I don't think it's necessary. If it was a simple ask, then that would be one thing, but I don't think that the benefit that we would derive from that is enough to warrant you going through the hassle.
Right.
So don't worry about that. That's fine.
Thank you.
I had a similar question on that same page though, regarding plastic surgery. There was again the decrease from 2021 to 2024. Dr. Gregg, do you have an explanation for that?
I would need to look at the data a little bit in more detail. I will reserve that at this time.
Okay. I would only note that the volume during that same period and projecting into the future is increasing despite the decrease in the CMI. So an explanation as a late file would be helpful on that.
Sure. Thank you.
One moment, please. Can we just go on mute?
Sure.
We are back.
Okay.
Mr. Jennings, if would like to respond to your question, if you'd like me to do it on redirect, I will, but he's prepared to respond to your question about the plastic surgery trend.
Sure, he can respond now. That's fine.
Sure, thank you. The plastic surgery change is due to recruitment, successful recruitment of additional plastic surgeons. In 2021, we really only had one busy plastic surgeon, and she was doing very complex microscopic microsurgical cases for breast reconstruction, 12-hour cases, which would have had a very high case mix. The additional plastic surgeons that have come on are not doing, they're doing more volume, but they're not doing the high complexity cases. And one in particular who's very busy is doing the post bariatric surgery, so post weight loss surgery. After a patient has major weight loss surgery, oftentimes they require or want plastic surgery. An example is a paniculectomy, or sometimes the surgery on the back of the arms for excess skin on the back of the arms. And the case mix index for those patients is much, much lower.
Okay. And when did he start? If you happen to know.
I think she started in 22. Yeah, 22. 23? Okay, 23.
And despite the lower complexity, those procedures still need to be performed in the hospital?
And we'll have Dr. Gregg respond.
Sure. So the determination of should a surgery be done in the hospital versus an ambulatory setting is really based, or one of the major considerations is the amount of comorbid diseases. And that is usually gauged by the ASA score from anesthesia, where you're an ASA 1, which is you have no comorbid disease, you're as healthy as you can be, and that's usually a safe patient to do in an outpatient ambulatory setting. An ASA 2, maybe you drink some alcohol or you vape or you have some sort of substance intake without significant comorbid disease. That is safe to do usually in the outpatient ambulatory setting. But when you hit ASA 3, you start looking at at least one significant comorbid disease. And that's when complications could potentially arise, which honestly, the ambulatory settings are not ideal for. And when you hit ASA 4 and 5, obviously those should be done in the hospital. So usually, even though you're doing reconstructive surgery for, whether the extra skin, added skin underneath the arms, the paniculectomies, many of these patients, even though they do have significant weight loss, might have sleep apnea, all right, which is actually known to cause, it puts you at risk for potential narcotic-related apnea that could be exacerbated, or diabetes that they're recovering from, and a variety of other things after they have bariatric surgery. So those surgeries should be done in the hospital based on their ASA score. And that's, again, this is something that is a determination based on a group of folks. It's the anesthesia, it's pre-op testing, it's the surgeon. And we make that determination as we move forward. And that's where, even though these have lower case mix indices, the reality is it's the best place for them to get care is in the hospital setting for their plastic surgeries.
Okay. And you just mentioned ASA 3 and up are generally performed, or 4 and 5 are definitely performed in the hospital. 3 is generally performed in the hospital. Is that like national standards, or is that St. Vincent's requirement, or how does that work?
I can say that in the variety of medical centers that I practice in, the ASA 1s and 2s are done in ambulatory centers, and 3s and greater are typically done in the hospital settings. I can't comment on the entire nation, but I can say in many of the hospital settings that I've served in, that is typically the cutoff.
And is that a determination that is set by St. Vincent's or by the doctors themselves, the team that you mentioned?
It's again, so because ASA takes in, it's at least one significant comorbid disease. It could be two, it could be, other things. And it also is the severity of said comorbid disease. It is taken into consideration because we have such a robust pre-operative or pre-admission testing center, is that the surgeon will say, okay, well, maybe this patient should be done in-house. They go to pre-admission testing, they get their full history and physical, we evaluate their comorbid diseases, it's reviewed by an anesthesiologist. Yes, we agree it should be done in-house. And then there could be a direct discussion, et cetera. But it's one of those things that by basic, physical exam and taking a history in the office, it can be determined very easily as well.
And are there any circumstances where, a patient may be right on the line? Like what would the default be under those circumstances? Would you leave it to the patient to decide whether they wanted to be in the hospital?
This is Bill Jennings. This is Bill Jennings again. I'm sorry. This is never a patient decision. This is usually
Okay.
anesthesia and surgery. It's a medical decision entirely.
Yes.
Okay. Okay, we are going to change trajectory dramatically. So I wanted to talk about those notices that were put into the notifications and filings portal in 2020 and 2023. And this is why I asked Barbara Dirty to be present, because she was the one who signed those. So a couple days ago, we put those into the record. Those are Exhibit Q. If you wanted to pull those up, that would probably be helpful.
It's in your binder. There you go. Here you go, Barbara. Here, Barbara.
Oh, thank you. Okay, I have them.
Just a background question.
Okay. Thank you.
Ms. Dirty, when did you start with Hartford Healthcare?
Oh, I have been Barbara Dirty, D-U-R-D-Y. I've been with Hartford Healthcare for 15 years, so at the end of 2009.
Okay. So St. Vincent's filings have stated that since it was automatically receiving approval under our statute for the addition of those two ORs, one in 2020 and one in 2023, it was only seeking an increase of 3 ORs. So as it stands today, you currently have 15 physical ORs that are in operation. Is that correct?
That are in operation, but we are authorized for 17.
Okay. Is there a distinction between authorization and actual ORs under the statute? The statute says an increase of 2 or more ORs within any 3-year period requires a certificate of need.
But I don't believe it says the ORs have to be in operation. So I'm not an attorney, so I can't give you a legal, definition, but I don't think the statute says they have to be in operation. I think you have to be, it refers the way I think about it, it refers to authorization. Because often hospitals are authorized for ORs that they're not using.
What do you base that on?
Well, I'm just thinking of some of our one of our hospitals is authorized for more ORs than they actually have in operation right now. So I know that it does happen.
Okay. So is there, I'll call it a limiting principle. Is there like a limiting principle to that position, that there's a difference between authorization and actual physical ORs that are in operation?
So I'm not sure what you're referring to by a limiting principle. Can you?
May I just, I'm a little concerned about the questioning because as Ms. Sturdy said, she's not an attorney.
Okay.
And she followed the statutory procedure at the time during the pandemic and pursuant to the master facilities plan. So I can ask some of these questions on redirect, but her intention was never to mislead OHS. It was to ask for the OR as allowed for under the statute. Whether or not it was actually implemented is a separate issue and was outside of her control.
Yeah, can I just give you a little background? Would that be helpful?
Sure.
So a little context. So in 2020, when the first notice was submitted, I was aware that St. Vincent's was engaged in a master facility planning project. And, they were looking to increase OR capacity. So they needed authorization at that point in time to add one additional OR as part of their master planning process. Then, obviously the pandemic hit. Those plans were put on hold for, at least a couple of years. And in 2023, I was aware that that planning process was being refreshed. The projections were being refreshed. And now there was a need for additional OR capacity. And they, obviously were not going to build out those ORs unless they had proper authorization. And so authorization for room 17, we sought to get, your approval for that prior to the build out of the 17.
So I'll go back to a question that I asked a minute ago. It doesn't require a legal interpretation, but like, say a competitor hospital like Bridgeport Hospital were to do what St. Vincent's did here, where they submitted the notification every 3 years, which they're permitted to do under the statute. Let's say they did that for 30 years straight and then suddenly added 10 ORs all at once. What impact would that have on St. Vincent's?
I'm going to have to object to the questioning. I think the point that we're trying to make here is that these were very extraordinary circumstances. The first letter was written in January 2020. 3 months later, the pandemic and everything shut down. Everything, including elective surgical cases in hospitals, were not being performed for at least 2 to 3 years. People did not want to go to the hospital. And what I think Ms. Sturdy said was that there's no history of this pattern. This was as a direct result of the pandemic. We are here before you today. The pandemic is over, asking officially for 3 additional ORs. We're not banking ORs for the sake of banking ORs. So I think the question is really unfair and prejudicial.
Right, but Ms. Dirty just said there are other examples, even within Harvard Healthcare, where they're approved for certain ORs and they don't actually have the ORs. So you just said this isn't a common practice, but
I think what she means is that based on her professional experience, she's aware that hospitals don't fully utilize all their ORs to 100% capacity. Obviously, if an OR is decommissioned, there are issues that we have to run by DPH. So it's not like there's this formalized banking process where the hospitals are abusing this statutory right to not go through this process, which is very time consuming and expensive, to ask for another OR. We could simply just wait and 3 years and not go through this rigorous process. And we would immediately, obviously, because of what you've seen in terms of testimony provided today, open that OR. It takes time to basically within the hospital itself to get the budgetary approval, to hire architects, to hire construction companies. These things do not happen overnight. So when she came back in 2023, it took some time, and that master facilities plan was underway.
That's correct. And I don't think that, you know, we wanted to start the actual building in construction without having that authorization. So that's, you know, why I submitted the second letter.
Okay. I do want to ask some more questions about this. So the first letter was submitted on January 13th, 2020. And it said effective March 1st, 2020, SVMC will have 16 operating rooms. What occurred between January 13th and March 1st to put that in motion?
In 2020?
In
2020.
2020 was the
Right.
pandemic.
There was a massive worldwide epidemic.
No, there wasn't. It was between January 1st or January 13th, 2020 and March 1st.
It's 3 months.
3 months.
Right. So
Yeah.
what happened during that 3 months to put that OR into operation?
Those plans were put on pause in January. I mean, nothing, we were in the throes of a pandemic. So the master facility planning project.
The pandemic hadn't hit. The pandemic happened in March of 2020.
We can answer.
Yeah, I
that.
understand the nature of your question now. The planning likely was underway at that time, but it takes months for architectural and engineering renderings, given the complexity of the HVAC systems and electrical systems. So nothing had been launched. And certainly there wasn't time in 3 months to open a newly constructed operating room. Really, everything got put on hold.
Would you agree? So it says effective March 1st, SVMC will have 16 operating rooms. Would you agree that someone reading that would assume St. Vincent's would have 16 operating rooms on March 1st?
Barbara, why don't you answer?
I would think that they were authorized to utilize 16 operating rooms.
So we could turn to the second page of Exhibit Q. That's the March 10th, 2023 letter. So the language actually changed for that letter. There it says St. Vincent's intends to expand its surgical capacity rather than actual ORs from 16 operating rooms to 17 operating rooms. Can you explain the difference in language there? Why there was the change from actually increasing your ORs to expanding your OR capacity?
Well, I think the language may be different, but I think what I was intending to communicate here is that we were seeking authorization to open the 17th or to operate a 17th operating room.
Okay. So we can move off that document for now. The application at one point says prior to COVID-19, it was planning to build 2 ORs. And I can give you the page number for that if that would be helpful. But let me just frame it, and then we can get to the specific pages if necessary. So, and this Ms. Dirty, this question can go to anyone, not necessarily you. It could go to Dr. Gregg or Mr. Jennings. So in the application, it says prior to COVID-19, St. Vincent's was planning to build 2 ORs. Then in response to the completeness letter, it said the 2020 master facility plan recommended increasing by 1 OR. And then in Mr. Jennings' pre-file testimony, he said in 2020, a master facility plan identified the need for replacement of the 5 ORs and expected addition of 2 ORs. So after all that, my question is, prior to COVID-19 in 2020, was there a need for 1 or was there a need for 2?
I think the plans had evolved, hearing officer. The plans had evolved as we had success in recruiting additional surgeons, even in the midst of a pandemic. The inadequacy of capacity became clearer as we were more successful in recruiting.
Okay. And prior to COVID-19, did you have the capacity to expand by 2 ORs?
Prior to?
I'm not sure
Could you
why that
could you
is.
clarify the question, please?
Yeah, I'm not, and I'm going to have to object for relevancy. We're here before you today with real facts and statistics demonstrating our need for 3 additional ORs. So to the extent that whether we needed 3 additional ORs or 2 additional ORs back in 2020 or prior to 2020, I don't see how that is relevant. We are allowed under the statute to request authorization for an additional OR every 3 years without the rigorous scrutiny that we're here today undergoing. So I have to object on the basis of relevancy.
So we can move off that question. So in different parts of the record, it says 1 OR was needed prior to COVID-19. And then 2 ORs were needed prior to COVID-19, and then back to 1 OR. And I'm just trying to figure out if prior to COVID-19, it was identified that you would need 2 ORs, why wasn't a CON filed at that point?
I can speak to current state. Based on our current volumes and our success and current capacity, we need 20 operating rooms.
Okay. When did the 2020 master facility plan, when did planning for that begin?
No idea.
I think the only one of you.
Can
Sure.
I just go on mute for 1 second? A couple of, first of all, I think that when we discuss the master facilities plan, I think that is protected by the motion for protective order. So
Right.
I would.
The contents of it.
Well, we are discussing to some degree the contents of it. Hartford Healthcare, just for the record, acquired St. V's in October 2019. Just prior to that, it was owned and operated by Ascension Health. So that was really all that I wanted to clarify.
So I'll ask a broad question. You went from needing either 1 or 2 ORs prior to COVID-19. And then in the 2023 update, you said you needed to increase by 5 ORs. So broadly speaking, what happened within that 3-year period that resulted in the 2.5 to 5 times increase in the need?
We conducted community needs assessments for physician need assessments, and were successful in recruiting new surgeons to the community based on that community need. And they've gotten busy.
So it wasn't based on any actual volume increases that we're seeing from 2020 to 2023. Is that correct?
Yeah.
Yes.
No,
Yes.
no, there were volume increases. Once the world reopened, we started seeing volume increases based on the new surgeons.
So according to page 16 of the application, the data submitted there was about a 13% increase over those 3 years. So what I'm trying to figure out is why are you saying you need 5 more when there was only a 16% increase at that time?
Table
Uh,
you're referring to?
I don't know. Can you please clarify what you're referring to in this main form of the CON application?
So surgical block cases, 61%, 77%, 83%. But if you look at the actual number of cases performed, it goes 6,516 up to 7,406 in 2023.
Okay, Dr.
I can take
Greg.
this. Again, so we have to remember that a case is not a case is not a case. During that time period, we actually recruited a complex hepatobiliary surgeon. We recruited neurosurgeons. We recruited surgeons capable of doing more complex surgeries. So this is what, what's interesting is that here you have the number of hours utilized. That's because there are more longer complex cases that you are using the time, but your absolute number of cases that might increase only 16%. If every single case was the exact same, time duration, et cetera, wheels in, wheels out, then you would see not only growth in utilization, but the exact same growth as far as percentages for number of cases performed. But if you're recruiting tertiary care level physicians, surgeons and physicians to perform these cases, then your utilizations will go up, but your number of cases may not. So when I have a hepatobiliary patient, a surgeon that takes 8 hours to do a case versus someone who does hemorrhoidal tissue excisions where they might do 8 cases, well, you'll see 8 cases during that time period. But for one surgeon, but you'll only see one case for the hepatobiliary. So the complexity of cases took up more time, but you didn't see a growth in the absolute number of cases because we're still using the time. It's just taking longer to do the cases.
Okay. Is it fair to say, based on a few of your statements, that like recruitment happens first and then the volume goes up?
Yes.
Yes.
Okay. So Mr. Jennings, in your pre-filed testimony, you make note of the fact that outpatient procedures are increasing at the hospital while inpatient procedures are decreasing. Although that was in your pre-filed, anyone can respond to this. Which specialties performed at the hospital are experiencing the greatest increases in outpatient volume?
Yeah.
Yeah,
Dr. Gregg will take that.
Yeah, Shea Greg here. So the specialties we're seeing the most significant growth in right now include orthopedics. They include acute care surgery. They're including thoracic surgery. I'm thinking about our most recent report. We actually look at this on a very regular basis because we want to make sure we match our needs to the community. Emergency general surgery in general across the board, specialty, regardless of specialty, is also increasing because, as mentioned, we had an increase of 15% this past calendar year in trauma. So that is producing more hip fractures, intracranial bleeds, et cetera. So those are the ones that are increasing significantly at this time.
Okay.
state that, please?
Hearing Officer Suka, Bill Jennings back again. And you had asked about the sequencing of recruiting versus volume arriving. I'd add one more step into that, and that is the successful recruitment of newly trained and highly trained surgeons depends on the adequacy and the modernization of the operating room. So this request of having 20 operating rooms also will help us address the needs of the newer surgeons that we're recruiting.
So I do have some questions about the MFPs. But to Attorney Feldman's point earlier, that was done through the confidential, that was submitted through the confidential process. So I think I'm going to reserve those for later. But we are going to have to do some of this in executive session. So continuing with the open session though, has St. Vincent's conducted any analyses for costs or revenue for surgeries performed on campus versus off campus?
This is Chris Given, VP of Finance. I don't have a specific analysis with me. As Dr. Gregg alluded to before, the determination of where surgery occurs is in the safest setting based on the patient need and determined by the surgeon and the anesthesiologist. Obviously, the lower complexity cases that are often done in an outpatient setting are also less expensive.
Okay. Dr. Gregg, back to you. In your pre-filed testimony, you discussed having to bump non-emergent surgical cases, and you also alluded to that in your earlier statements. Is this bumping common practice in the industry?
The answer is I've seen it performed in other facilities that I've practiced in.
But it's not ideal, obviously, right?
It is far from ideal. And I can say that when bumping occurs, if you're lucky, you might slightly delay one surgeon. But I've had situations where there was an urgent case that actually changed the start times of probably about 10 patients and 5 surgeons. So this is something that, again, it's bumping is one term, flexing is another. The bottom line is when we have the good news here at St. Vincent's is we have a clear triage based on condition of what takes priority in access to the OR. And we need to have that as a verified level 2 trauma center. Plus, it's the right thing to have regardless. So everybody's on the same page. And this was approved through our surgical governance. And the bottom line is it is in the facilities that I practiced in, I would say it is a common practice.
Okay. So in the issue responses, St. Vincent said that they don't track the number of cases bumped. Just a follow-up question on that. Does St. Vincent's or Hartford Healthcare have any metrics on the cases that are bumped? Like percentages or anything along those lines?
We're going to just mute for one moment, please.
Okay.
Hearing officer? Chuka?
Yep.
We do have some data that is in our application that is responsive to your question. Can we please have Sam respond?
Yeah,
Sure.
this is Sam Peringer for the record. In the literature we provided on benchmarks for certain OR metrics, it states that the case cancellation rate for hospitals in this study is about 1.7%. And you were asking about, are we in a range that's relevant to other benchmarked hospitals? And we're bumping 2 to 4 cases a day, which is around 10% of our cases every single day. So we're bumping and moving and canceling a lot more cases than we see in benchmark data across similar organizations.
Okay. Can you refer me to a specific page that you're looking at?
Yes, it is.
And if you
Yeah.
could provide the page number in the middle bottom that starts 00, et cetera.
63 00063.
Okay. Thank you.
You're welcome.
Related to this bumping, in the application and in Mr. Jennings' pre-file testimony, it says that there are delays and unnecessary wait times. So we were curious, does St. Vincent's track delays or wait times?
No, we do not.
Okay.
I think, though, we could provide some anecdotal information if that's of interest to the hearing officer from Dr. Gregg.
Sure, that'd be helpful.
Yeah, so there's, as far as the downstream effects, I will defer to Mr. Jennings regarding his comment. As far as the classification system, if you classify a case as an A, B, C, D, or 24 hours, that means you're 15 minutes into the OR, 2 hours into the OR, 4 hours in the OR, 8 hours in the OR, all right, based on the pathology that you're up against. We track if we meet those metrics. So if there is a 15 minutes time into the OR, then we do track to see if we hit that metric because that's a requirement for verifications and other things. So the front end, we track actually very closely. The back end is basically, they have to, the rooms have to flex accordingly. And that's, again, a major, from a trauma surgeon standpoint and a person who's been doing emergency general surgery for almost 22 years here, that's the most important thing is that upfront. And then we will basically take care of the patients accordingly, downstream.
May I redirect? Because
Sure.
I think, yes, Dr. Gregg, with respect to just anecdotally, your experience as the chair of the surgery department, on average, when individual patients are bumped or delayed because a more acute case is taking priority, what is the average amount of time by which the patient is delayed on average?
Yeah, on average, I would say it's going to be about an hour to 2 hours, and I work very closely with nursing staff. Very complex situations of bumping and, moving cases around are all art to me and my nurse manager, or excuse me, my operations manager. And the bottom line is, I would say an hour to 2 hours with other downstream delays with other patients is very common.
And would you offer the patient the option of rescheduling on another day?
Yes, we will always try to do the right thing based on the patient's other comorbid diseases. If they need to eat, if they feel that medically it is the right thing to do, we will always offer that as a secondary option.
So is it true then that typically the delay time can be anywhere from 1 hour to 24 hours to 3 days in terms of rescheduling?
That is accurate.
Thank you.
Okay. Dr. Gregg, in your pre-file testimony, you said your responsibilities include having to, quote, develop a forward-thinking plan for ensuring the right and full complement of needed surgeons. Is that plan reduced to writing anywhere?
I will not say it's reduced to writing, other than a variety of emails, notations, strategy that I participate in with the health system and both the local level and at the health system level. I've been practicing in Bridgeport for well over a decade. And I'm very familiar with the patient population, the community, especially being a trauma surgeon. And I think, as mentioned in earlier testimony, constantly reevaluating the needs of the community based on anything from, physicians moving out of the area from other health systems to, programs that are not available, that are available in other, similar cities to Bridgeport and the surrounding communities. This is an ongoing fluent evaluation. And I can say easily that even though it's not reduced to writing other than some emails, it will be discussed in strategy meetings. It'll be discussed at budgetary meetings. And it'll also be discussed on a monthly basis through our surgical governance meetings, et cetera. In addition to, getting intel, so to speak, from individual surgeons and patients. So no, there's not a formal plan that I'm expected to produce on a regular basis, but again, the needs of a community vary. They change on a monthly basis. And I thank you for asking the question, but this is something that is, it's important, extremely important to me and extremely important to the people around this table. And it's done on a regular basis, I can say.
Okay. So in your pre-file, page 139, you have a couple tables there. Did you have any involvement in preparing those tables?
try to find these tables. Oh, at these,
No,
No,
your
in the
on
pre-file.
my pre-file.
Which table are you referring to?
These tables.
They're both on page 139. 17 OR suites is one, and then the other is 20 OR suites.
Oh,
And I
yeah.
believe the 20 is also included in the issue responses.
Yeah, and so this is 000139, those two tables?
Correct.
Yes, the answer is I have reviewed these and with the authors of this, of these tables, yes.
Okay. So, and you mentioned this earlier too, but by 2028, you're projecting 85% utilization based on total hours of utilization. So let's say in 2028 you discover you need an additional OR or 2 or 3 or 4 or however many. Will you have the capacity at that point to just expand within St. Vincent's existing framework, or will additional construction be needed?
I'll defer that as far as the answer to Mr. Jennings.
Yeah, well, we would have to start a new construction project at that time. We're full on the third floor now. In fact, the 6 new operating rooms that are going to be opening in July are new construction on what was formerly an administrative suite. And if the 20 operating rooms are running by 2028 and are at 100% capacity, it would require new construction.
So it was also stated that anything over 80% is not ideal. So should you actually be seeking more than the 6 that you're currently seeking, or sorry, not the 6, the 3 or 5 that you're currently seeking right now?
It might be the case, but what we're requesting today is 20.
Okay.
And point of clarification, it's anything greater than 75% is the typical national statistic that they use. If you have utilizations greater than 75%, then considerations for additional OR builds should be taken into consideration.
Okay. I don't recall seeing that. I recall that the 80%, and I know that our facilities and services plan says 80%. So what's the 75% based on?
This is based on literature, and it was provided in my my submitted testimony, my verbal testimony today.
Is there a reference in your
Yeah, this is Sam Peringer. It's page 00061 in the same document I had mentioned earlier.
All right, just give me one moment. All right, I'm not familiar with OR Manager Inc. Is that a reputable, reliable source for this sort of?
Yes.
Okay. I'm assuming you wouldn't have provided it if that wasn't the case, but I decided to ask the question anyway. All right. So you also stated earlier that you have added or will be adding approximately or a total of 37 surgeons between fiscal year 2021 and fiscal year 2024. What do they all perform surgeries in ambulatory centers, or are some of them only at St. Vincent's? Are some of them only off campus? What's the breakdown there?
Sure, I can't give you an exact percentage, but what I would say is that the majority of them are actually hospital-based. There are traditional, at least based on our markets, traditional specialties like ophthalmology that traditionally does strictly outpatient surgery in surgery centers. So have I recruited some ophthalmologists into the fray as part of that 37? The answer is yes, a couple. So they will stay in the outpatient setting. Have I recruited a couple ENTs for the purposes of either call or whatever? They traditionally will do a lot of their surgeries in the outpatient setting. But when you start getting into neurosurgery, more complex robotic-driven orthopedic surgery, spine surgery, for which we've recruited 2 spine surgeons, as well as a whole host during that time of neurosurgeons. These surgeries need to take place in a hospital setting. So I would say the majority of our recruits are operating during that time period within the hospital setting.
And in various places in the record, it's been indicated that some of them are replacements for people who are retiring or winding down their practice, and others are entirely new. Do you know how many are replacements versus new?
I can't give you an exact percentage at this point. I would be happy to look into it.
So my reason for asking that question is, if they are simply replacements, you would expect the volume line to stay the same, basically. So there must be some other explanation for the increase.
May I redirect to help
Sure.
you? Okay.
Yeah.
So to the extent that some of these new recruits are replacing retiring surgeons who have slowed down.
Yes.
So when these retiring surgeons are retiring, are they operating at a full capacity level typically?
Typically, no. As part of the retirement of a standard surgeon, many times they will wean their volume potentially as low as 25% prior to departing an institution.
So that if you are replacing a retiring surgeon with a new surgeon, newly trained surgeon, which is typical of your recruits, you would expect to see a significant growth associated with that replacement. Is that correct?
That is correct.
No further questions.
Okay. Dr. Gregg, would it be possible for you to a moment ago you said you would have to take a look at it to determine how many were replacements versus entirely new surgeons? If we asked for a late file, would that be possible?
Yes.
Okay. And if you can also break that down by specialty, I'm assuming you would do that anyway rather than by name. That would be most helpful.
No, thank you for the direction. Absolutely.
So Dr. Gregg, you were previously at Bridgeport Hospital, is that correct?
That is correct, for 9+ years.
So Bridgeport Hospital has added only 1 OR since May of 2016. They now have 21 ORs. Do you have an explanation for, the differences that the 2 hospitals are experiencing in terms of volume growth?
I can't comment on volume growth at this time. I can simply talk about the historical growth of the ORs, where there was the acquisition of Milford Hospital, which again was thought of as one campus associated with Bridgeport Hospital, and that came with, I believe, 4 ORs at the time, 3 to 4 ORs. And then there was the Park Avenue project that also had the addition of ORs. So that was during my my tenure there at Bridgeport, but I can't comment too much more on volume
Currently.
growth, like current volume growth over, especially over the last 2 to 3 years.
Okay. I would like to take a 10-minute break.
Before we, can I just do one redirect on that last question, please?
Sure.
Dr. Gregg, with respect to the needs of another hospital in the city of Bridgeport, do you have firsthand knowledge of what those needs are?
No, of another hospital outside our health system, no. Not at this
Right,
time.
so is it fair to say that you cannot conclude that both hospitals are equal?
That is fair to say.
Okay, and would you say, based on your prior experience at one hospital and your current experience at St. V's Medical Center, that the referral sources are the same?
There is variability, there is clear variability between the two hospitals when it comes to referral services.
So would you say that your referral sources for surgeries at St. V's is different than it was at your prior position?
That is correct.
Thank you.
All right. Thank you. Let's take a 10-minute break. I think I have to think about this, but I think I'm going to try to get through the open portion of the hearing before lunch. Then we'll take lunch. We'll come back for a quick executive session, public comment, and then we'll wrap the hearing. So should be done by like 2 o'clock at the latest. But let me speak with the team and see if that makes sense from their perspective. I was hoping to get this done before lunch, but I worry that I might be pushing it by doing that. So Attorney Feldman, do you have any thoughts in terms of scheduling going forward? I know you don't have any idea of how many questions I have left, but
No, we're amenable to whatever the needs of OHS are.
okay. All right, let's take a 10-minute break and we'll come back at 11:53 and I'll have a better understanding of what we'll do going forward.
Thank
Maida,
you.
you can stop the recording. Thank you. So this is the certificate of need hearing regarding St. Vincent's Medical Center's application to increase its ORs. It's docket number 24-32757-709. And we had a lot of the technical portion earlier. We are going to try to wrap up the technical portion now. So I directed the applicant to page 39 of the application when we were off the record. Going to look specifically at ENT surgeries. So if you're looking at those numbers, there was a significant decline from fiscal year 2021 to fiscal year 2024. And then if you compare that to the issue responses that were provided, so there were 6 surgeons in fiscal year 2021, 6 in 2022, 7 in 2023, and 9 in 2024. So you see this decline in ENT, but you see an increase in actual physicians. So the question is, like, you know, what explanation can you provide for that?
Sure, I can take that. Shay Greg here. In order to maintain a trauma center, it is imperative to have an ENT panel. It's a requirement, actually, according to the American College of Surgeons. During that time period, especially early on, where you saw the increased number of cases, we had more cases being done in the hospital by ENT surgeons. Due to attrition and a variety of other reasons, and also movement of those cases into more ambulatory settings, we actually saw a decrease in the net number of cases during that time. However, in order to maintain our call panel and be available for our trauma patients, I needed to recruit surgeons that were able to cover the call, respond to call-based emergencies, et cetera. So what you see is that the individuals are not necessarily the same. And so when it comes to the actual surgeons along that time period, you will see a slight increase in surgeons, but they are not necessarily doing their surgeries in our operating room, and they are taking call for us, but they are surgeons that I have recruited while I was, as I've been chair. So whereas back then we had surgeons that were doing more cases in-house, but since then, a lot of those cases have gone to the ambulatory center, and we've seen decreases in numbers. Hopefully that addresses that. Thank you.
It does. There was, so in your projections, there's an increase of, so you go from 21 in fiscal year 2024 to 82 in fiscal year 2025. And then
Yes.
there's an increase afterwards. So, and there's only one ENT physician that's being added in 2025. So what is that physician providing more surgeries in the hospital?
Yes. So we are excited to be embarking on a program where it's base of skull surgery. And there is an ENT OMFS specialist who has training for that highly specialized surgery to partner with our neurosurgical colleagues to bring volume to take care of that patient population. How it technically works is that the ENT will gain exposure, the neurosurgery will resect whatever tumor or whatever mass that is in that area, and then the ENT will assist with the closure with the neurosurgeon. This is something actually we're excited to start this week, and we anticipate significant growth in this, given that it's such a needed but extremely rare service, especially in Fairfield County and the state of Connecticut.
So it's rare, but you're still expecting the jump from 21 to 85 in fiscal year 2025?
I want to make be very clear about this. It's not a matter of the tumor issue or the pathology being rare. It is a matter of having access to this service being rare. So as opposed to surgery, people having to drive miles to different states to get access to this specialty service, we are excited to be able to provide it in Fairfield County for the citizens of Connecticut. This is, again, assessing our needs and responding to the needs of the community.
Okay. And you just mentioned that for that specific procedure, there are actually two different physicians, two different surgeons performing the surgery. That's still considered an ENT surgery, or is that captured twice in these numbers? Like it would start ENT and then be captured somewhere else, like spine or neck?
Yeah, the answer is no. So there are certain surgeries that require two surgeons.
Sam.
Okay, so Sam can clarify. Okay, very
This
good.
is Sam Peringer for the record. The numbers you see here do not reflect cases that are done by two surgeons twice. So if a case is done by two surgeons, it's only counted once in these numbers.
Okay. And it would be like the primary surgeon.
It's the primary,
Like this one
correct.
would be ENT, even though there's base of skull surgery as well.
Yep, it's the primary surgeon, and if there's an assist on it, it's not counted again in this number.
Okay. Going to shift to hand surgeries next. Again, there was a decline there from fiscal year 2021 to 2024.
This is Bill Jennings. That can be addressed by the migration of hand surgery moving to outpatient settings as well.
Okay. You're adding a hand surgeon in fiscal year 2021. And you could see the increase from 43 in fiscal year 24, 78, 25, 78, 26, 84, 27. Overall, though, there's been a loss of one surgeon, and the cases dropped. Actually, you know what? Let's just move past that. That's a really complicated question. And I don't think that
I think we could answer it. I think it
Okay.
might be helpful.
Yeah, I think it's important, and thank you for the observation. I think what you're seeing is actually we are seeing more hand trauma cases being either coming through the front door to our emergency department or referred to us because the hand specialty is, again, a unique resource that trauma centers have. So when we do project higher at this point, there are as Mr. Jennings said, there are more elective cases that are heading towards the ambulatory centers. However, we are seeing increases in hand trauma that are being referred to us from the state and the region. So I anticipate that these projections are reflective of not only elective surgery, but we have to remember there's emergency surgeries that also are coming to our center, and that's where we anticipate these projections.
So I remember my question now. So there was a loss of about 200 surgeries on an annual basis. Well, from fiscal year 2021, there was 247, and then fiscal year 24, there was 43. So, and there was a loss of only one physician during that period of time. And you're adding one physician in 2025. So why was there a loss of 200 surgeries per year associated with one surgeon, but an increase of only, I think, 30 to 40 cases from the addition of that surgeon in fiscal year 2025?
We're going to answer that, please.
Yeah, we had a surgeon that retired and left the organization that was doing a majority of those cases you see in fiscal year 21.
Okay. So, and the surgeon that you're adding will not be doing the same number of cases as he was doing?
In the main campus ORs, we migrate as many of our cases.
Okay.
Sam, you want to answer?
Yeah, that's correct. Joan spoke correctly. In the main campus ORs, they won't be doing the same type of cases that were done historically.
Okay. So if we were to look at the information and projections that you supplied confidentially, we would see an increase in hand surgeries there in the ASCs.
We don't know if they go to, yeah, that's right.
Actually, I don't think you provided projections in
No,
yeah.
and there's some opacity around the private practice operating rooms. A lot of the orthopedic surgeons own their own ORs, and we don't have visibility to that data, and a lot of the surgery is done in their proprietary operating rooms.
So when you say their own, you mean non-HHC affiliated?
Yes, that's correct.
Okay.
Wholly owned
Yep. Okay.
by the surgeons.
So looking at urology surgeries, there were some interesting numbers there as well. There was a drop from 480 in 2021 down to 280 in 2023, and then a huge increase in 2024. Can someone speak to those fluctuations?
Yeah, that's a lot of that.
Your name.
Oh, sorry, Sam Peringer speaking here. That is turnover of certain physicians in that time period. and recruitment and building up of that practice over time.
There were urologists on staff, though. It remained relatively consistent between like 35 and 40 over that period. So wouldn't that refute that claim?
No, this is Bill
Or-
Jennings. It actually doesn't. It supports a point previously made by Dr. Gregg that when you replace folks that are retiring with newly trained specialists, oftentimes they bring new skills and more complex procedures. Some of our urologists who retired weren't doing any procedures. They were on the staff, but they really weren't active surgically anymore based on their age. And so when you replace folks that are retiring, oftentimes this is what you see.
And just to further the comments here, there is medical staff membership, and then there's actual surgeons that operate. So there are many people who maintain their medical staff that did, let's say they are heading towards retirement. They were active at one point, you know, and they may maintain their privileges. But as you do recruit these new folks, I mean, there are brand new procedures, like, you know, state-of-the-art procedures that are being done by our newest recruits in partnership with the Tallwood Institute that is being offered very uniquely in Fairfield County at this point. So in high volumes as well. So this is a matter of where the skill set is evolving, privileges may be maintained, so you don't necessarily see major changes in the number of surgeons, but of those people who are on the bench versus, you know, on the court, so to speak, that is evolving. And that's why I think you actually are seeing that major bump. In fact, I know that's why you're seeing that major bump during that time, because that's when the Tallwood surgeons were recruited and they came in and started doing a lot more procedures.
Okay. Taking a step back a little bit, the 37 physicians that have been recruited and who have started since 2021, to your knowledge, do any of them have medical staff privileges at any other hospital?
You know, there some may. Some of our medical staff members are employed by Hartford Healthcare, but not all. So there are medical staff members who are still in independent private practice. For example, vascular surgery, orthopedic surgery, and gynecological surgery, to name a few. So I wouldn't know if those independent private practitioners who are on our medical staff have privileges elsewhere.
May I redirect?
Yeah, I think you see where I'm going with this.
Yeah, so Dr. Shea, with respect to the surgeons that are the basis of these projections and statistics, do they perform all of their surgeries, inpatient surgeries at St. Vincent's Medical Center, or do they split their time with another hospital?
The majority of the new recruits performed the majority of their surgeries at St. Vincent's Medical Center.
Okay, so. Okay.
That answers the question I was going to ask. So thank you. Now we just have sort of some miscellaneous questions that are going to jump around a little bit from topic to topic. Why does St. Vincent's use a 35-minute turnover instead of the standard 30 minutes?
Dr. Shea.
Sure. So Shea Greg here. We are constantly striving towards that 30-minute mark. Again, we name our yearly metrics. We would love to name it as 28 minutes. We'd love to name it as 20 minutes. But the bottom line is we will always try to get better is the bottom line. And if this year's metric is 34 minutes, I would love it to be 30 minutes. So,
And redirect on that.
sure.
With respect to your smaller ORs and the way that the ORs are laid out,
Mhm.
does that contribute to taking time or more time in terms of turning cases over?
Yes, and actually to summarize, the more complex the case that we are doing, especially when you have multiple trays, multiple technologies that need to be appropriately cleaned, managed, and turned over, those will take longer times, whereas your straightforward cases, small open cases will take less time. But if you look at all the averages put together, we constantly will strive to get better.
And so as a follow-up question to you, with respect to some of these smaller ORs, is it more difficult to set up in a smaller OR, which has less space and less flow, than it is in a large modernized OR that has standard equipment in it already, that is wired to go?
Yes, depending on how many trays, which usually multiple trays are required, regardless of case, whether it's minor, major, and then there's variability in that definition. But the bottom line is, if you have a smaller space, it's going to be, you want to maintain sterility. That is your number one goal. So there could be some extra time that's added based on maintaining sterility, ensuring sterility, and setting up a room.
So in the application, St. Vincent's indicated that it reserves 2 ORs currently for trauma purposes and emergent stat cases. Is this reservation of ORs common practice in the industry?
Yeah, we're going to mute for 1 second, hearing officer.
Sure.
So could you ask the question one more time? My apologies.
Hopefully. Hang on. So page 19 of the application, St. Vincent's indicates that it reserves 2 ORs for trauma purposes and emergent stat cases. So it's 1 for trauma, 1 for emergent stat cases. So total of 2. is this sort of reservation of rooms standard, and is it a standard ratio as well? Is two like the ratio you would expect for a hospital of your size?
The answer is yes. And it's backed up by other centers that have level 1 trauma centers, level 2 trauma centers that are extremely busy, similar to ours, and for cardiac programs as well that have perfusion machines on standby in the event that there is a cardiac emergency. Yes.
May I redirect?
Certainly, yeah.
Okay. So when you, Dr. Gregg, state that these two ORs are, quote, use the word in the question, reserve, is it you reserve meaning that you don't, is it reserve or dedicate those ORs for a particular type of surgery?
So clarification, they are dedicated ORs for usually trauma-related cases and then emergency cardiac and/or emergency cases as you described in our application. So, yes.
So my follow-up question to you is, to the extent those two ORs, which are going to be outfitted for particular types of surgery, so they're always standing and ready to go for cardiac surgery or trauma surgery, presumably with advanced equipment.
Yes.
Okay, so if you're not using those ORs and you need OR capacity, will you use them for other cases?
Yes, because again, they're for
That's good.
emergency purpose.
Okay, thank you.
All right. So that's all the questions I have for open session. I do have a few that I think we'll get through pretty quickly in executive session regarding the master facility plans. So if you will all indulge me, so the following procedure will be utilized for any occasion. So this will be the only occasion where we need to go into executive session. So I will announce who's going to be participating from OHS. That'll be me, Steve, and Annie. And also Boyd as well. Maida will stay here. So Attorney Feldman, will you be having everyone in the room participate? Okay.
Yes.
And so once we go into executive session, I'll advise the court reporter that the transcript from the executive session will be designated confidential and not subject to disclosure. And once he has completed preparation of that, it will be provided to the ohs.confidential@ct.gov email address. And we will only share it with Attorney Feldman via email, and then she'll figure out who can receive it from that point forward. So let's see. So we're going to, in a minute, take a short break, and then we will start up the other link, the other Zoom link, and we will keep this one going. We'll have a slide up on the screen that just indicates that the parties are in executive session and that we'll be back momentarily. We'll make sure that there's no transference of one to the other. So we'll have everything muted in the open session, and we will make sure that anyone in the executive session will have they won't be in the regular session as well. And then once we're done with that, we will all come back to the open session utilizing the link for the open session. And I think that's it. Attorney Feldman, do you have any questions in terms of how this is going to work?
No.
Okay. So as I mentioned, the individuals who will be present from OHS will be me, the CON staff that is assigned, the court reporter, and everyone who is currently in St. Vincent's room right there. And Melissa, I don't think we have your last name. Would you mind just providing your last name for the record, or have Attorney Feldman announce it?
Mayfield.
Oh,
Go ahead, Melissa.
It's Mayfield.
Mayfield?
Yes.
Mayfield?
LD.
Okay. The only reason I ask is the court reporter is going to need that. So thank you. Okay, so we're now going to exit, and I will see everyone in the executive session. Maida, you can stop the recording. Thank you. We are back in the open session of the hearing in docket number 24-32757-CON regarding St. Vincent's Medical Center's proposed increase of 2 or more operating rooms within a 3-year period. We just held an executive session. I made no decisions. It was for the sole purpose of receiving information on the confidential material that was submitted previously. We're going to turn now to the public portion. We haven't had any members of the public sign up. So we are going to turn our attention to the late files now. The late files that I have written are number 1, the presentation that was provided earlier, the PowerPoint presentation. We'd also like so that the block number 2, the block slides, we would like those updated to reflect utilization of all ORs, or how the time is blocked for all of the ORs. And with the ORs identified that would be decommissioned. And number 3, a list of the 37 new recruits and whether they are replacement versus new, broken down by specialty. So, Attorney Feldman, is there anything that you wanted to discuss about those 3?
Just reviewing my notes. I think that you asked us to also identify with a legend the types of cases that are associated with color blocks. Is that
Correct.
true?
Yeah. So the second one the second late file that I just referenced that included like all of the information, that would be updated to include the legend as well.
Correct.
Okay. Well, I am prepared to go forward with closing remarks if you would like to do that. If you'd like a 5-minute break, that's fine as well.
No, I'm ready to go. I'm surrounded by very hungry people.
Okay.
So my closing remarks are very short. And I just want to sort of reiterate some of the focal points in today's technical portion. I'm going to start with Ms. Barbara Dirty. As you know, there's a statutory provision that allows hospitals to request an additional OR. There's no requirement under that statute which provides or stipulates or requires a time period for when those ORs are to become operational. And just like all CONs, actually, when a CON is obtained and approved from the Office of Health Strategy, it is typical that it is understood that execution of these projects, it doesn't happen always immediately. In fact, it's rare. And that is typically why there's a 2-year period by which the applicant gets to implement the project. And sometimes the applicants cannot implement within 2 years and they're required to come back and get a modification. So the fact that the ORs, let's say in January of 2020, were approved and not implemented by the time the pandemic occurred in March of 2020, it would be almost unheard of for that to occur. And then, of course, once the pandemic occurred, we don't need to reiterate or explain to OHS the devastation and the impact that the pandemic had on the focus of resources for most healthcare providers and the reality that surgeries were, came to a grinding halt. So all of these statistics during 2020, 21, 22, and as you also know, were greatly impacted by the pandemic. And we also know that many hospitals experienced challenges financially. That is why the federal government and the state government provided advanced funding and grants to help the hospitals get through this, to regain their footing. So it's quite normal and not unexpected during this particular period of time, shortly after the acquisition of this very important hospital, that there would be disruption and that things would change with leadership, with coming out of the pandemic. And that is really the world we were dealing with. We're not banking ORs by just randomly asking for things so we could, willy-nilly have them when we decide we need them. They were asked for because we believe they were needed. It is not a small community hospital, and 15 ORs is actually a very small number. I don't mean to make any comparison, but the Cleveland Clinic's main campus has 191 ORs. The Mayo Clinic's main campus has 150 ORs. So we're basically asking for 20 ORs for a hospital that is licensed to have 500 staff beds. So I don't think anything that we put before you is particularly extraordinary or silly or ill-purposed or irrational. In fact, I think they've been very patient, very reserved, very conservative in their planning and waiting to rise out of the epidemic and re-engage with the master facilities plan, which is something that the community absolutely needs. I think when our planner, Ms. Dirty, submitted those letters, there was no intent to deviate from one letter to the other. These are pretty much drafted out of whole cloth. I think the intention was to seek authorization, not to say we're immediately going to be operationalizing 16 ORs. What we meant was we have authority to operate 16 ORs or 17 ORs. So the idea of going on an archaeological dig and resurrecting what this letter said or that letter said, I think I want to bring OHS to the present, where we are today. And what you heard from Dr. Gregg is that Bridgeport, the city of Bridgeport, receives an extraordinary number of trauma cases. One of the 5 cities in the state that has some of the highest trauma calls in the state. And we've experienced in just 1 year a 15% increase in trauma cases. They represent a variety of different trauma cases, some of them gun violence, some of them, like Dr. Gregg described, elderly patients experiencing very significant adverse events that bring them to the hospital. But we don't want to, we want to respond to those trauma cases, but we also don't want to neglect our patients in the community that have non-emergent cases. We would never want to create or build ORs that we didn't need or couldn't use. What we did here in this particular scenario is we went forward to modernize our operating rooms. We did this simply because we needed to. 5 of the 15 ORs were really ill-suited and could not accommodate advanced imaging and advanced surgical technologies that are geared to using minimally invasive surgical techniques. That is the goal, for surgery to be lower cost, people to have better outcomes and get back to work sooner. People can have their tumor removed from their kidney and be back to work in 3 days with minimally invasive surgery. I know this for a fact. And this is ideal. This is good for everybody. And so we went ahead to modernize our ORs, understanding that if we didn't get approval to add 3 ORs, we would simply have to close 3 of those suboptimal smaller ORs, which we need and we very much can utilize. We've incurred the cost to modernize those ORs. It's not incurring a cost to add ORs. We've already incurred that cost because we needed to. So to close 3 ORs arbitrarily, which we very much need, and you heard Mr. Jennings state that it would really be inefficient and not serve the interests of the surgeons, the patients, the community, to close 3 of the ORs on this level 2. We would only have 1 OR there, which we couldn't really function well or effectively or efficiently that way. And as Dr. Craig, I think, very ably demonstrated, we need these ORs based on where we are today. When you take the snapshot consistently since we submitted the application, in fact, our actuals far exceed what we projected. So I think that I've pretty much summarized the importance of this application to us. And I hope that OHS will consider the testimony provided before us today and approve the 3 ORs. I have no further comment. Thank you.
Thank you, Attorney Feldman. I'm not going to ask any more questions, but I do think it's important that I address something you said in your closing. Can you hear me?
That is the end of my closing.
I think you
Do
may
you
have
want
lost.
more?
I'm sorry?
Happy to keep talking.
No,
What?
I think you're not hearing all the words that I'm saying for some reason.
Yeah. That's the end of my closing.
Can you hear me?
Yes.
Okay. So I'm not going to ask any more questions, but I did want to address something that you said in your closing. And when I say this, I'm not speaking on behalf of the agency. I'm just speaking on my own behalf. But for you and for the benefit of anyone watching, I'm very concerned with your interpretation of the statute and regulation. And your position that you can provide notice of increasing ORs and then not actually increase ORs at that time. As you just pointed out, a CON is good for 2 years. And here we are 5 years after you provide the initial notification and you still haven't established that OR. And we're more than 2 years after the second notification as well, and you still haven't established that one. So I'm not going to count that against you, but I am concerned with that interpretation, and I would just ask that you and everyone else going forward keep that in mind, because frankly don't think that's an accurate interpretation of, or certainly what the intent was of the statute and regulation.
Well, in all due respect, I don't have the legislative intent in front of me, but I understand in representing other hospitals, that's certainly how it's interpreted. And I also understand that these were very extraordinary and unusual times during a pandemic. And I could also say with great confidence that had the pandemic not occurred, this construction and renovation would have been done. And we would have been coming back to you today, asking for 3 more ORs just the same.
Understood. Thank you.
Thank you.
So I have nothing further. Thank you all for attending today. A reminder again, for anyone from the public who's attending that you can submit written comment to concomment@ct.gov. I am going to, I just realized, how long do you need for the late files?
2 weeks?
Okay, that works. So this hearing is adjourned, but the record will remain open until closed by OHS after we receive your late files. So thank you again to everyone. Thank you for pushing through lunch, and we will be in touch.
Hearing officer, will you be issuing an order with the request for the late files? Thank you.
I will issue that in writing tomorrow by end of day.
Thank you.
Thank you very much. You can
Thank
stop the
you.
recording.